conducted a first-in-human phase 1/2A clinical trial called the PETRA trial, where we assessed the PARP1 selective inhibitor called Seropram, which is highly potent and highly selective for PARP1. During the dose escalation, we explored doses from 10 milligrams all the way up to the highest dose of 140 milligrams once daily. We found that the drug was safe, well tolerated, and really associated with very infrequent dose interruptions, dose reductions, and drug discontinuations. Importantly, we also found that we were able to achieve much higher pharmacokinetic drug exposures as well in patients, and also very robust pharmacodynamic target inhibition with greater than 90% power relation inhibition. And during dose escalation, we actually saw responses, so RECIST partial responses at every dose level. And that really provided the rationale to then proceed to a dose optimization expansion cohort, where we focused on HER2-negative breast cancer patients with either BRCA1 or BRCA2, PALB2, or RAD51C or D mutations. And there was no limit on their prior lines of chemotherapy. And again, what we found was looking at safety, pharmacokinetics, pharmacodynamics, and efficacy. It really was very favorable, especially versus the first generation PARP1 and PARP2 inhibitors. There was an overall response rate of 48.4% and a median progression-free survival of 9.1 months. The current approved PARP inhibitors are all PARP1 and PARP2 inhibitors and trappers. But we know to shrink cancers and to benefit patients, we really need to focus on the PARP1 inhibition. And so that provided the rationale to really dial out PARP2 and to really create this PARP1 selective and potent inhibitor called Seropram. So Seropram is the first-in-class PARP1 selective inhibitor, where we have been able to really drive drug exposures up in patients safely without the side effects or the severity of some of the side effects that we have seen with the approved PARP inhibitors. And the hope is that by achieving much greater drug exposures and pharmacodynamic effects and hitting the target hard enough in a sustained fashion, that we can ultimately achieve much greater efficacy. Potentially, it may also allow us to combine Seropram with other drugs in rational combinations as well. Currently, this has already moved on to phase 3 clinical trial testing in prostate cancer in combination with new hormonal agents.